Hi friends, today I'm going to talk to you about emergency treatment of hyperkalemia, which can be a very dangerous emergency, and we'll talk it based on the European Resuscitation Council guidelines. Now the patient can present to you, they can be very sick, such as in conditions like diabetic ketoacidosis or Addisonian crisis or severe sepsis or DIC, or they may have taken drugs like ACE inhibitors or potassium sparing diuretics, or maybe some toxins, or maybe having an underlying kidney disease and may have missed dialysis. So you assess them using your primary survey ABCDE approach, and then take a 12 lead ECG and monitor cardiac rhythm, connect them to a monitor. Now exclude pseudo hyperkalemia, because that is very common if the drawing the blood from the patient was quite difficult, because of that can lead to cellular damage, and the potassium can be spuriously high. So but consider treatment for arrhythmias if hyperkalemia is suspected. So you treat on based on what you see. So either it can be a mild hyperkalemia between 5.5 to 5.9, where you continue observing them for system for any underlying illness and monitor the serum potassium, or it can be moderate 6.2 6.4, or severe 6.5 or more. And so in these cases your approach is check if there is any ECG changes, because hyperkalemia can trigger dangerous arrhythmias. So they can be flattened T waves, flattened P waves, tall T waves, broad QRS, and or they may have bradyarrhythmias or ventricular tachycardias. Now your first priority in these cases is to protect the heart, and you do that by giving IV calcium. So either 10 ml of 10% calcium chloride IV, or 30 ml of 10% calcium gluconate IV. Now repeat ECG and continue monitoring them. And next thing you could do is your approach is shift potassium into the cells, for which you use insulin glucose IV infusion. Now glucose insulin infusion prepared with 25 grams of glucose based on what you have. If you have a peripheral line, suggest using a 20% or 25% glucose, or even 10%, and then give over 15-30 minutes with 10 units of soluble insulin. Consider that it can cause hypoglycemia. So if your initial blood glucose is low, start a glucose infusion. The second approach to shift potassium would be salbutamol continuous nebulizations. And then you can use potassium binding resins thereafter to remove potassium. You monitor the potassium, and in the end find what was the cause.